my name is Dr. Christy Winthizer. Thanks for joining me today. The goal of today's video is a teaching demonstration about respiratory assessment. You'll see me do 3 learning style or teaching styles today. You'll see lecture, audio clips, as well as demonstration. Let's get started. The student learning objectives today is to verbalize the components of inspection during a respiratory assessment, describe how to evaluate symmetrical expansion and tactile fremitus, compare and contrast different lung sounds, as well as demonstrate a comprehensive respiratory assessment. So the first thing we're going to do is inspection. And when we first start with inspection, we're just looking holistically at our patient. How do they look to you? Are they comfortable? Are they leaning forward and gasping for breath, or are they lounging back in their bed and carrying on a conversation? Do they look anxious or worried about their breathing? Their color, are they pale or cyanotic? And then their level of consciousness. So are they sitting up and talking to you? They're probably oxygenating fairly well. Or do they appear confused and maybe not oxygenating well? So first we're looking holistically at our patient. Then we're going to look more inspection in terms of our respiratory status. So what is their rate and their depth of breathing? Are they having retractions? Are they using accessory muscles? Maybe they have a much rounder chest or barrel chest, and that's going to signify some air trapping, like what we talked about last week when we talked about emphysema. After inspection, we move to palpation. First, I'm just going to palpate that chest wall for any masses or lumps. In females, we're going to spare the breast area, but otherwise I'll do anterior and posterior chest. Then I'm going to check for tactile fremitus. So tactile fremitus is where I place both palms on my patient's chest, and I have them say a word such as boat or coin, and I feel for that vibration. I should feel it equal on both sides, but we know that sound is conducted better through fluid or a solid. So if I feel one side much more has much more vibration, then I worry about a fluid collection in that area. So here's a visualization for that. So again, you're going to feel that vibration against your hands. If it's increased fremitus or more vibration, we think about a lung consolidation such as fluid or mass. If it's decreased, then we think of excessive air in the lungs, so something like emphysema, chronic bronchitis, or a thickening of the chest wall, so something like a pleural effusion that just doesn't even allow that vibration to come through. The other part of palpation is symmetrical expansion, and that's really just making sure that both sides of that chest equally open. So you're going to put your hands on the back posterior of your patient, and you're going to pinch just a little bit of skin between your 2 thumbs, and then you ask your patient to take a big breath. And as they take that big breath, your thumb should equally open so that one isn't opening more than the other. So that's palpation. The third part of any assessment is percussion. This is not a skill that I'm asking you to master. This is much more of an advanced skill. You'll see providers do it, and they do it because they're trying to figure out if there's dullness or hyperresonance. And hyperinflation or extra air trapping will be hyperresonance. That very dull sound will be from atelectasis or pleural effusion. So if you ever see a provider put their hands on the back of a patient, oftentimes they'll put their hand out and they'll tap on their finger, and they're listening for that sound. And so they're trying to determine if there's dullness or not. Again, percussion is not something I'm asking you to do today, and will not be something that we practice. The next part is auscultation or listening, and this is probably the most important part that you can do. So a couple of techniques or tips that can get you in a good spot. First of all, if the patient can, get them sitting upright. That way you have good real estate in terms of being able to listen to the front and the back. If they can't, then you're going to be rolling them to each side so that you can listen to the front and the back. Got a lesson on the patient's skin, okay? And while we're doing that, we're going to certainly protect our patient's privacy, but you will miss something if you listen over the gown of a patient. You will hear a little bit of gown rustle and may not hear what you need to be hearing. So always on the skin. It's not always something you see in practice, but we got to get back to listening on the skin. You're going to listen front and back, and you're going to listen during inspiration and expiration. So this is not something that you just rush and you do 1, 2, 3, 4, and maybe don't even listen through the whole inspiration and expiration, because you're going to miss something. So this takes a little bit of time, this part of the assessment. To get started, I would encourage you to just listen and find normal. You're not always going to know what abnormal is, but if you learn to determine what normal is, then you're going to get better at picking up that abnormal. Once you start appreciating what an abnormal is, then you can decide what is it. And that's going to take a little bit of time to figure out. Okay, the two sounds we're going to focus on today is wheezing and crackles. So as you're in practice, find your normal. If you hear something abnormal, that skill will start to develop in terms of you being able to pick out what you're actually hearing. So let's listen to a couple of lung sounds in just a minute. First, I want to show you the images of how we listen. So anteriorly, we're going to listen from one side to the other, and then we move down. And so you can see that we're able to compare and contrast each side as we move down. Another thing to keep in mind is where those lung sounds are. So if we're listening out on the edges or the clavicular line here, we're going to hear those vesicular lung sounds, which is really what's happening in the alveoli. If we listen high up, we're going to hear just bronchial, and then in the middle, we're going to hear bronchial vesicular. So that's helpful for you to understand that lung sounds are not going to sound completely normal from here to here, but they should sound the same depending on where you're listening. And then this image is really important to understand if we think back to your anatomy and physiology class, that the right lung has 3 lobes, the left lung has 2. So you can see located here where that right middle lobe is. And so making sure that if we just go from here to here and then hop down underneath the breast, you have the potential to completely miss that right middle lobe. So keep in mind where that lobe is. Posteriorly, the same thing. We're moving from left to right and back and forth, moving down so that we can compare and contrast. And again, we have either vesicular or bronchial-vesicular lung sounds, depending on where you are listening. That right middle lobe we kind of lose when we listen posteriorly. So we mostly get the lower lobes when we're listening. So just remember that if you're listening just on the back, you're not going to get to that middle lobe. Okay, let's listen to a couple of sounds. This first one is going to be what a normal breath sound sounds like. At the beginning, you hear a little bit of clicking, which is just artifact from the listening tool. And then as the video goes on a little bit, you hear more of the normal heartbeat. So this is normal. Let me start it back at the beginning here for us. Oops. All right, here we go at the beginning. So that's normal breath sounds. Let's listen to some different sounds then. So next, we will listen to crackles. And crackles is when we have fluid in that alveoli, and those alveoli are popping open. You'll see that oftentimes with pneumonia or an infectious process. And then next we're going to listen to wheezing. And wheezing is more likely to happen in times of bronchoconstriction, such as asthma. All right, so that's wheezing. So as you're listening to your patient, ask yourself, are these breath sounds present, decreased, or increased? Are they normal for the area? So should I be hearing vesicular sounds up here? Nope, I should just be hearing bronchial or vice versa. Are they equal on both sides? And if I hear something else, what do I hear and when do I hear it? Just on inspiration or just on expiration? And that can help us determine what disease process we have going on. So consider, if you hear an abnormal sound, what's going on in my patient that may be causing that sound, as well as what interventions do I need to consider. So next we're going to move on to demonstration. I'll show you quickly what a respiratory assessment looks like, and then I'll have you break up into pairs to work with a partner and practice that demonstration. So do I have a volunteer to help me? Sure, come on up. So a respiratory assessment starts with inspection. So first I'm just going to look at my patient as a whole. I'm going to look at their comfort level, their color, and how easy they're breathing. So I'm looking at this patient holistically. They appear to have good level of consciousness. Next, I would inspect their respiratory system. To do that, I would take off their shirt and their gown and provide them a private setting. And I would look at their chest, their rate of breathing, and their depth of breathing. After I've inspected my patient, then I move to palpation. So palpation is feeling their chest wall for any lumps or bumps. And I would feel for pain and discomfort, and I'd also feel on the back for the same thing. Next, I can do tactile fremitus, and again, that's placing both my palms on the back of my patient, and I'll ask them to say the word boat.
Boat.
And I'll feel for that vibration in my hands, and it should be equal on both sides. If it's more vibrating on one side or the other, then I think of that area that's more being fluid filled. Then I'll ask them to turn to the side here to be able to do symmetrical expansion, putting my hands on their back, pinching the skin a little bit, asking them to take a big deep breath. Good, and I should feel my hands move equally. You can turn back, thank you. Next is percussion, which again, we're gonna skip over. So the next part is auscultation, and is that listening part. For ease of time, I'm not gonna listen to each breath through inspiration and expiration, but I'll demonstrate to you the anterior and posteriorly. So anteriorly, I'm gonna start at the top, and I'm gonna move from 1 to 1, and then 2 to 2, and 3 to 3, with 4 to 4, at least 5 times anteriorly, making sure I'm getting right where that right middle lobe is located, and making sure that I'm listening through an entire inspiration and entire expiration. Next, I'm gonna move to the back, and I'll have you rotate again. And I'm gonna do the same thing with 1, listening through inspiration and expiration, and then moving from side to side and down, comparing and contrasting each side from left to right and left to right. And I'll move through that at least 6 times. Again, if my patient can't sit upright, I'm gonna have to roll them from side to side in their bed to be able to do that. Thanks so much for volunteering. You can go have a seat. So that is the end of auscultation, and that's probably the part that takes the longest in terms of making sure that you're hearing each lung field. So that ends our lecture today on respiratory assessment. I'd like you now to break up into groups and practice respiratory assessment with your partner, and I'll walk around and help you guys out. Thanks so much for joining me. Have a great day.